Okay, welcome to the Culinary Medicine Interest Group podcast. Today we have Dr. Osband with us. She's an assistant clinical professor of pediatrics, and in addition, she also works in curriculum development at NYMC. I'm going to have her introduce herself.
Hi, everybody. I'm so thrilled to be here. My name is Yardaena Osband. I have basically been at NYMC my entire career. I graduated from the Sackler School of Medicine at Tel Aviv University. I then did my pediatric residency at the Maria Ferrari Children's Hospital. I have served in a variety of positions at NYMC, including being the pediatric sub-intern clerkship director. My newest position is I am the director of longitudinal curricular themes, which is basically a very fancy way of saying that those areas in our curriculum like nutrition, genetics, that sort of don't fall under a typical course. I am charged with doing some updating and revamping and seeing how they fit into the curriculum. I am also a pediatrician and recently as well became certified as a lactation consultant through the International Board Certified Lactation Consultants. You can look at their organization. It's iblce.org. I'm also a mother of 5 children. So I've had a little hands-on experience, just not as a pediatrician, in feeding my own children as well.
That's all incredibly exciting. And like John said, we're very excited to have you on our podcast today and to get to talk to you about some of these questions about pediatric health more in depth. So kind of to start things off, I'd love to talk to you a little bit about breastfeeding. I know you mentioned that you just recently became certified and now you're a lactation consultant. So for a lot of our listeners who may not necessarily know too much about the nutrition of breastfeeding, I'd love to ask you, what are some of the nutritional benefits of breastfeeding your children?
Well, the real nutritional benefit is that that's really how babies are supposed to eat. So when we do give them formula, they're not getting what they're supposed to be getting in breast milk. And so some of the major difference, sort of the textbook or let's say the board question is going to be that, in mature breast milk, let's say, there's more whey, right? This has to do with the proteins that are in the milk. That's about at 60% and the casein is at 40%. Whereas that formula, they have tried to work to sort of make it, the same, that it's now sort of also 60-40. But in some, in some formulas, it's going to actually be more, and it's not going to get that ratio exactly the way that it is in breast milk. Besides just the nutritional content itself, what breastfeeding does is all those immunoglobulins, it's basically giving passive immunity to the baby. So before babies can get their first set of vaccines at 2 months of age, this was sort of, in a way, I think of it as the world's or the most natural vaccine, right? Babies get these immunoglobulins from the breast milk, and it basically protects them against, against a variety of diseases. And additionally, there's been a lot of other work that's been done about, decreased incidence of obesity in babies who are breastfed, babies who are exclusively breastfed. There's a decreased rate of food allergy. So this is a podcast for medical students. And I think this is all information that anybody can sort of easily look up. Where I view myself, so I don't think I'm saying anything that's sort of, earth shattering, and I went not into a lot of detail. Where I look at myself or where I could be helpful on this podcast is that I think many of us have not really had exposures to babies, maybe grew up in a home where we were not breastfed. And I think we have to recognize that part of the question about breastfeeding versus formula, it's a really highly charged emotional issue. So I can tell you, for example, when I have a new mother come into my office and she would like to breastfeed, but let's say her mother did not breastfeed, right? That becomes very charged, in a way, it's sort of rejecting what your mother did before. I think another challenge today is, as we're seeing many different types of families, right? Adoption, fostering, same-sex partners, that also presents a whole new set of challenges with breastfeeding that the pediatrician and the medical community in general really needs to become sensitive to. And the answer can't just be, nope, you can't breastfeed. But the third piece of that is that, what we sort of call the mommy culture wars, which I think is that, yes, I will be the first to advocate, breast is best, but I really don't like that phrase. I think that has such a negative connotation for babies who do end up getting formula for a variety of reasons. And so there's many of us who really like to say instead, fed is best. I will be happy to talk to any parent, medical student, or resident or colleague about what are the benefits of breastfeeding. But I think we have to figure out how to talk about these things where parents still have choice and we're not judging parenting choices. And unfortunately, I think the whole topic of breastfeeding has become one of those hot topics where there is a lot of judgment or, just not all around good feelings and some of that competitiveness over parenting.
Yeah, I think that's a really important point you bring up. We as medical students will talk about breastfeeding and infant dietary patterns in terms of the medicine and the biochemistry of it and the food part of it. And sometimes we neglect to also think about all the other cultural parts of it, the socioeconomic constraints, the availability. What about mothers who are undergoing XYZ condition? For some mothers, they could develop mastitis. It could be very hard to breastfeed. And so I think you raise a really good point. As important as it is to talk about the nutrition of breastfeeding, it's also as important to mention the social constraints and kind of, like you said, breaking down those stigmas and those barriers about, feeding your children. At the end of the day, like you said, fed is best. I would love to ask you, though, I know that you mentioned this.
Sorry, let me just add one thing to that, right?
Okay, go for it.
Sorry. So I think you're spot on about that. And, when we teach breastfeeding or nutrition, and this is one of the things I want to be working on in the medical school, is, we'll have a class about what are the nutritional benefits of breastfeeding, but we don't do a lot about the management of breastfeeding. And thinking about this also in terms of like a health system science perspective, which is one of my other hats here at the School of Medicine, we can tell every mother or any parent, who breastfeeding is a possibility for, great, you should breastfeed. But, what's our maternity leave policy or family leave policy in this country? It does not really support, people who want to choose to breastfeed. And so I think there's really a whole host of issues. Just, management is not taught well in medical school. And even on top of that, all these socioeconomic factors that really lead to the United States not having great breastfeeding rates.
Yeah, I mean, as a female in medicine, I could not agree more. That's something that I think about when I think about, my future and family planning, et cetera. It's not always something that is discussed. So I appreciate you talking about that and bringing more awareness of that, not only on this podcast, but within our school and the beyond too. So what I was going to say is, I know that you mentioned earlier a point, you talked about allergies as it relates to breastfeeding and not breastfeeding. Can you talk a little bit more about that, or how, I guess, parents who maybe use formula could be, supplementing better, being more mindful of that, or what are some techniques to mitigate?
So this is really an area of medicine that's sort of changed as I've been in practice. So as I mentioned before, exclusive breastfeeding for the first 6 months of life has been shown to significantly lessen severity and risk of food allergies, especially in families with strong family history. When I began my career as a pediatrician, sort of the old school way of approaching allergies was that there were certain foods that were sort of more typically children or toddlers could be highly allergic to, right? Like nuts, tree nuts, fish, eggs, things like that. And so the advice we gave was, delay giving them. And then after age 3, you'll introduce them. Really, the research is showing now that maybe that was not the best approach. And that if you don't have a strong family history of allergy, right? If you do have a strong family history of allergy, that's actually a different question how to manage that. But that maybe these sort of highly allergic foods actually should be introduced earlier. And sort of the most famous example of that is that in Israel, there's a very popular children's snack called Bamba, which is a peanut snack. It's sort of like a peanut puff. And everybody feeds this to their babies, as soon as they can start, the way we have like those puffs here. So that's kind of their puff. And everybody gives it to their baby. And it's literally a puff coated in like some kind of peanut powder. And they actually have a very low incidence of peanut allergies. And a lot of that research has actually come out of that. So, we're sort of starting to recognize that actually earlier introduction is important. Again, these are for families without incidence of food allergy. That's a different discussion how to do that. But, that's some of the things that have sort of started to change, even as I've been practicing, over the last decade.
Yeah, I know. I've been reading a lot about that too, and it's very interesting. Going off of that, so, nowadays as medicine has shifted, we've also seen the prevalence of a lot more food-related allergies and conditions. There's a lot more people developing celiac disease and different allergies as well. So as, let's say, as a mother who maybe has celiac disease and is worried about maybe their child doesn't test for the gene, or for whatever it is, they're worried about how, their diet may affect their child or their child's ability to tolerate foods better. Can you touch on that?
Do you mean that from a breastfeeding perspective, or from like what you just feed your baby, how you start to
probably how about from a breastfeeding perspective? Like, maybe we can shift it towards the direction of how does your maternal diet affect your composition of breast milk, or maybe the different things that your child can obtain from breast milk?
So there really are not a lot of foods that are off limits while you're breastfeeding. That's very different than pregnancy. And in fact, I often tell, new moms, some of it is just trial and error. So with my oldest, who's now 20, the one food I could not eat is when she was 6 weeks old, I once had a hot, delicious pastrami sandwich, and she developed like terrible, you can name it, gas, foul stool afterwards. And I couldn't figure out like why she was so fussy. And then I realized, it was because I had this pastrami sandwich, So there is sort of a thing within breastfeeding babies that some foods will sort of make babies a little bit more uncomfortable. Broccoli, onions, sometimes your caffeine can make babies a little bit jittery, but there really isn't like a food that you need to avoid. However, we do see some babies that do develop what we call sort of more a food intolerance. And that is on the spectrum of an allergy. The most common would be, a milk protein allergy. And in those cases, breastfeeding parents do need to do an elimination diet. So we'll often start with eliminating milk and soy, right? Because there's actually a very strong correlation that if there's an allergy to the milk protein, about 50% of those babies will also have an allergy to soy. Some doctors even recommend eliminating beef itself. And, sometimes there are, parents who will mothers will end up on these very limited diets of like chicken, sweet potato, and one other thing. But if you're at that point, you should be followed by, some other specialists. It's important to make sure the mother's getting the nutrition that she needs, as well as the baby themselves.
Actually brings up an interesting point that I wanted to ask. If you're making all these changes to the nutrition of the mother, how do her nutritional, I don't want to call them inadequacies, but how do her nutritional changes affect the infant's growth and development, or do they at all?
So, that's a really big question within breastfeeding. And I think one of the things that's sort of important to remember is that as much as we sort of want to make this science and data driven, sort of as long as the baby is gaining weight and doing well, we're not examining the nutritional composition. And I think that's one of the challenges, because when you have formula where sort of all the ingredients are very laid out and we know specifically what the calorie count is, sometimes families will get very taken on that. There is a thing where you can do what's called you can actually measure the fat content in breast milk. And yes, sometimes the composition of the nutrients will be impacted by what you eat, but I would not say that's something that we're super focused on when we think about breastfeeding.
kind of on the flip side of this, I know there's been some research on this and it's kind of a debated topic. You were saying how what the mother's eating, et cetera, sometimes can affect breast milk composition. It's not something we look
Well, let
at.
me clarify. We really don't think it does. Like, in other words, what you
Okay.
produce is what the baby's supposed to have.
What?
Yes, it
Yeah.
might
So that
somewhat, or if
that
you have
was
a very
my
restricted diet,
that
but
was my question.
yeah.
As your baby, advances in age and development, um, do those needs that it takes on, are those reflected in the breast milk? Like, does your breast milk composition change in relation to what your baby's needs are as time goes on?
So what we do know is that mothers do need more calories, right? A parent who's breastfeeding will need more calories because it just takes calories to actually produce milk. But the overall composition of your breast milk, yes, there's a difference between colostrum, which is that first milk that comes in that's very immunoglobulin heavy. But overall, the composition of breast milk probably stays pretty consistent. And there could be a lot of variety of diet. The one thing that I would say is that we do right now supplement babies with vitamin D. And that's probably because most people today are deficient in vitamin D. There are some studies being done where maybe we would supplement the breastfeeding parent as opposed to the baby. But that's one thing that we do actually monitor and think about. But again, it's really just sort of like you eat what you eat. The baby's going to get what they get, and not, again, I feel like some of my job as a pediatrician and lactation consultant is to sort of make this a relaxed process. And I think today parenting has become almost like an overload of information. And I know that it comes from a place of, first of all, like we can Google anything. There's so many books. But one of the things I always talk about with parents, especially when they're ready to transition to solids, like you don't need a 600-page book to tell you how to feed your baby, right? Like baby food is a very relatively new invention. We didn't have baby food, until very recently. So you just like feed the baby.
Yeah. And, I know that you and I have had this conversation before, but I think it'd be really interesting for this podcast as well. On the topic of baby food and that transition, there's all this information, like you said, misinformation, information, overload of information, overload of products, this baby food, that baby food, you hear about these toxin, this organic baby food, and it becomes a whole mess of what can I feed my child? I'm looking at a shelf of 500 different products. And I know that you have a very, I wouldn't say unique, but a good take on that transition of what you should feed your child when you want to transition to solid. So I'd love if you talked a little bit about that as well.
Thank you. So just to wrap up though, our breastfeeding discussion, again, I think it's important to realize the composition of breast milk in terms of nutrients, sometimes even protein and fat is going to change, but that's what's amazing about it. It's that the body is responding to the age of the baby, the frequency of the feeding, and what the baby needs. And so in a way, don't overthink it. Sort of just like let the body do what it's meant to do and what it naturally does, so well. And then it comes to a point where we do want to start giving a baby some solid food and that experience. Even within the pediatric community, there's a little bit of a difference of opinion. The breastfeeding people will be like exclusive breastfeeding till 6 months. Some people will say no, anywhere from 4 to 6 months of age, you can start introducing things. It's really a developmental stage. So the first piece of deciding when is your baby ready for solids is really, are they developmentally ready? So that means they need to really be able to support themselves in a high chair, right? Most 4-month-olds can't do that. They're sort of slouched, So I would say on average, it's more like a 5 to 6-month-old. And then they also really need to be expressing an interest in food. So it's really important to share some meals with your baby during the day, starting at 3 or 4 months, have them watch you eat. But there will be a time where you're eating in front of your baby and, they will be watching that fork going from plate to mouth and they will get angry. They will be mad. They will understand that they are missing out on something. And that's sort of the other developmental, milestone that you're looking for to know that your baby's ready to try solids. when we do introduce solids, it's important to keep in mind it's not really for nutritional value. The nutrition is really coming from breast milk or formula. And this is really just so babies learn how to eat, develop their oral motor skills, learn how to taste. And so that's why it's really important that, some parents, what they start to do is they will sort of blender or pulverize everything in a blender. And I've had parents who were giving like chicken that way in a bottle. Food is meant to be on a spoon. Or food is meant to be eaten by hand, which will obviously happen a little bit later. So it's also important when we start this stage that we're feeding them solids the way that solids are meant to be eaten, because it's not really the nutritional content that we're interested in. It's more the experience and the pleasure of eating, which is what we're trying to have the baby start to learn and enjoy. And that's why they really only need to be fed about once a day at the beginning. It should be calm in the house. So if you have a day where you're running around or you have an event to go to and your 5-month-old misses a feeding, that's totally fine. They can just be on their breast milk or formula for a 24 or 36-hour period. They're not missing out on anything. That's really where their primary nutrition is coming from. And so we basically say, it's introducing one new food every few days to make sure that there's no reaction or anything like that. But the real thing I like to emphasize with parents is this should be a really fun activity, and this should be enjoyable for you and your baby. It should not be a source of stress. And really sort of, not to overthink it so much. And again, you were talking about sort of all these organic foods, and, I almost want to make an assignment for medical students that they should one time go into Buy Baby or Babies R Us, or even like a Target, and just see the amount of products that are now out there for parents. And then I think you'll get a much bigger understanding of why so many people are sort of paralyzed with indecisiveness, because everybody wants to be doing the best thing for their children. But there's so much out there, and it's really hard to figure out, do I need or all organic? Which bottle is the best? What spoon is the best? I tend to have a little bit more of a very laid back approach, and I often feel that my job as a pediatrician is not to say this is right or this is wrong, but to really healthfully respect that there is a multitude of ways to raise children. We see that in the variety of wonderful cultures that inhabit our planet and in humanity. And so my job is really to be there sort of as a helper to figure out with families what's going to work best for your family, right? I want to share information about things that we know are dangerous or unsafe, or things that we know proven through research and science are best practices, but there's not really one way to feed a baby. And so we'll have, babies from some particular cultures where they're started on rice and beans, at 5 months of age. And that's okay, because that's what their culture is. And if grandma wants to make that, let grandma make that. It's not, for me to say they're not allowed to have that. And so I think we have to really respect feeding is super cultural. And so that's not going to be any different when we feed a baby.
Yeah. And I think that's like a really wonderful point that kind of almost brings us back full circle with what we were talking at the beginning about the importance of being more culturally aware and being aware, not only, like you said, of just how many choices are available and the quantity of information, but being aware of how to better counsel patients and meet them, where they are. We talk a lot in our culinary medicine interest group about nutrition education that's, culturally competent, that, looks at SES, looks at different cultures, looks at all these other constraints in the real world that parents have. And any patient may have too, and really working on how can we best advise patients on what's, not only the most achievable for them, but what's going to achieve the best results long term. Because like you were saying, if you told, a parent who is from, let's say, a South American background who, has a certain diet that they eat that they would like to, bring their children up, and you suddenly tell them you should ditch the rice and beans and you should give them instead some organic acai baby food that's at the store with XYZ antioxidants, like they're going to look at you and they're going to say, I'm never going to buy this. I might buy this once, but maybe I can't afford to buy this, for whatever reason. But it's not going to be, something that they can implement long term, because it's not something that it is something that they're comfortable with. And so it's really important to be able to advise patients and parents and whoever, it may be on advice that's feasible and that they can implement, that, like you said, it should be fun. It should be something that they want to do. At the end of the day, feeding is very personable. So are diets. And I strongly believe that one of, the best ways that you can start cultivating a healthy relationship with food is by making the food process enjoyable and not putting, these demands and these restrictions and looking at all these, micromanaging the food. In some cases, yes, it is important depending on the medical condition, and it's important to be aware, but to a certain level where it doesn't take away from the mindfulness and the experience of the food itself.
Right. This should be something that is enjoyable with your children and with your baby and should be part of the fun of parenting. And I think, really being a mindful parent is not to allow sort of all that outside noise. We humans have been doing this since the beginning of time. So we know how to do it. And we sort of just have to listen to each of our individual inner voices that speaks to us, of how do we want that experience to be within our family unit? And it's going to look different from family to family and for baby to baby.
I wanted to go back to something you've mentioned a couple times throughout the conversation, which is the idea of incorporating this information into medical school curriculum. So I just wanted to ask, how do you feel like this is accomplished most effectively, and what do you feel about the importance of incorporating nutrition education, both in the scope of breastfeeding and as a whole, to the medical school curriculum?
So I think one of the challenges with any piece of medical school curriculum, and this is not specific to NYMC, is, we sort of have the science piece of it, and then there's sort of the clinical management piece of it. So I think most schools are very good at the science piece, right? Like you'll get a class on the composition of what breast milk looks like versus formula. You'll understand what a protein is and a carbohydrate and a fat. But a lot of these clinical pieces that we discussed today, you may not have an actual opportunity. And even thinking about what a typical pediatric clerkship looks like, especially if you're training in a tertiary care system, you may not have as much exposure as you should with sort of just some basic nutrition. And even I would say that about the adult service, right? You're dealing with really sick patients who may have more medically complex nutritional issues, right? The ability to swallow or not swallow. Can you use a gut or not use a gut? And so I think the more common nutritional issues that come up in clinical practice, right, which is really going to be what we see in outpatient medicine, doesn't always necessarily get covered. And so, one of the things that I really am thinking a lot about in this new role as the director of longitudinal curricular themes, I'm not going to make everybody say that 5 times fast, is to really think about, how can we make that much more of the experience for our students at the School of Medicine. And, can we create a variety of opportunities, where it's part of the regular curriculum, but also, electives or other experiences for students who have a special interest. And that's why I think, the Culinary Medicine Club is amazing. I think it's starting to do a lot of that work. And I always look at it as a faculty member. It's not just me doing it as a faculty member, but it's really working with students and finding those students who are interested and partnering together to really make these types of changes on the ground, which I think, help everybody because ultimately we just want to be great physicians and, practice the medicine as excellently as we know we should be and want to be.
Yeah. And I think those are all, incredible and very valid points. And I think that's something, that we as a club and we as a student body are really appreciative and really looking forward to. Like you talked about, we have, this great clinical piece and this great science piece. And we touch upon, we do touch upon, social health and all of that goes into it, but really bridging those together and really translating what we're learning through our curriculum, into the clinics, into the community, into patients' lives, and being able to do that through nutrition and through all these other different, longitudinal curriculums, I think is really going to help us be more well-rounded physicians, and not just during our residencies, but in beyond as well. So We thank you for all that, you're helping us to do. And to close up, we have one last question that we always end with. And it tends to be the one that, all the physicians and faculty are like the most nervous about for some reason. But it's, if you were going to present a dish on MasterChef to Gordon Ramsay himself, what would your signature dish be?
Oh, well, I'm going to go really out there. I
Okay,
love to do old school Jewish cooking. So there's can I do two signature dishes?
go for it.
Okay.
Go for it.
So there are two dishes that I love to do. One of them I don't eat, but the people who love it, love it. So there's a sort of there's a dish that's very traditional that we have like on Shabbat morning, which is called kichel, which is basically, it's kind of like, it's just like flour, egg, a little bit of schnapps and some sugar. I bake it flat. It's just amazing with everything. I happen to love it with like a little whitefish. This sounds very Jewish right now, but it's delicious that way. My other really signature dish, which is an acquired taste, but I think we have to also recognize economically where it came from, is something that's called picha. Very few people know how to make it. It's essentially garlic jello. And it comes out of the idea that when people were poor, they would use every single part of the cow to make food out of it. So I feel like as much as people make fun of it, we have to recognize, from our heritage, like why people were making things like this. So it's essentially you take cow hooves and you boil them overnight with an onion. And then, the water from that, I know everyone's grimacing as I'm saying this, it's basically jello. And you season it with a ton of garlic and salt and pepper, a little egg. It's an acquired taste. I'm not going to tell you that it isn't, but those are sort of my two signature dishes that you may not get in a lot of other places. Now, some people may be scared to come eat in my house, but I make a lot of other good things too. I love to cook and entertain. So
Thank you very much for that. Those are some very unique recipes that I personally have never heard of before, but now I have to go seek them out somewhere.
Yeah,
I'm happy to
you're gonna
whip
have
up
to
some
feed them
kiffle
to
for you.
John.
The chat you'll probably pass on.
Yeah, John, now you can't come complaining if suddenly you're like, I have to eat, cow hoof jello.
Right.
You said it on the podcast for everyone to hear.
I did say it.
You did say it. Okay, you're on.
Well, thank you, Dr. Osband, for this lovely conversation. And I appreciate you taking the time to talk to us.
Thank you so much for having me, and keep up all this amazing work that you're doing.